Good morning. The meeting will come to order. And good morning, Madam Secretary. I want to thank you for appearing before us today. The ranking member and I have agreed this morning to allow the chair and ranking member of the Health Subcommittee to give the opening statements this morning. And after that, we'll begin with questions where we left off yesterday. We had the Secretary of the Treasury here yesterday. We were not able to get through the entire panel. So I'll now recognize Health Subcommittee Chairman Brady for his opening statement.
Thank you, Mr. Chairman. Secretary Sebelius, thanks for joining us today to discuss the President's 2014 budget. One of the top priorities for this committee is to act now to save Medicare so that every generation of seniors can count on it. So I welcome the inclusion of some conceptual reforms to Medicare, including recognizing the urgent need for a permanent solution to pay local doctors fairly so they can continue to treat our seniors, and improvements to the current Medicare structure to modernize cost sharing. However, the President's budget falls far short of what's needed to save Medicare. Its trustees tell us this important program is going broke sooner rather than later. The White House and Congress need to act together now, this year, to save Medicare for the long term. And I challenge you and the President to save Medicare for its own sake, not conditioned upon ringing tax increases from hardworking Americans that has nothing to do with Medicare. This committee will act. At the direction of Chairman Camp, we're convening a series of hearings beginning next week to examine bipartisan solutions to save Medicare, some supported by the President. I invite you to join this committee in working toward long overdue actions that protect, improve, and strengthen Medicare. Both Republicans and Democrats can agree that Americans need the right kind of health care reform, reform that lowers costs, improves health, and protects the vulnerable. But many Americans are concerned the Affordable Care Act may not be able to deliver. They have real concerns about how the law will affect their personal health care, that the President's law will cause health care costs to go up, while the quality of care goes down. This White House repeatedly promised it would lower costs by thousands of dollars for individuals and families, and that Americans would not lose the health insurance they have and like. Yet, you recently admitted that the mandates in the new law will make health care premiums more expensive. And this week you warned that almost 25 million Americans will lose the insurance they get at work. Clearly, the President's new law is not helping families or local businesses, and this budget does nothing to offer them relief. To add insult to injury, as our economy continues to struggle and millions of Americans have given up looking for work, the health care law is resulting in fewer jobs and frozen wages. It's forcing local businesses to replace full-time jobs with part-time jobs. In one survey from the U.S. Chamber of Commerce, over 70% of small businesses said the President's health care law prevents them from hiring new workers. Another study found it would put over 3 million jobs at risk in the franchise industry alone. And as one small businessman in Virginia stated, I'm convinced the primary reason we aren't seeing a robust economic recovery is the uncertainty and costs associated with this health care law. In a wood pallet plant that I toured in Conroe, Texas, the company owner told me the extra health care costs from the President's new law is equal to opening 2 new plants and adding 100 new workers. Our local businesses and their workers are worried. They're asking, why are my health care premiums going up? Why am I losing the health insurance I have and like? And why does Washington keep heaping on new red tape that keeps me from growing my business? These are serious questions I hope you can answer today, Madam Secretary. On top of the $2 billion already spent to set up the bureaucracy for this new law, the President's budget seeks $1.5 billion more, including adding 1,000 new IRS employees to ensure Americans comply with the new taxes and mandates. But what we really need are 1,000 more doctors and nurses, not more IRS agents. And finally, will the White House be able to deliver on October 1? 3 full years after the law was passed, this administration seems in disarray as it rushes to set up the health care exchanges by that date. With just 6 months to go, no one has any idea how many and which Americans will be forced into the exchanges, how they'll operate, what the health insurance plans will look like, or if Americans' private information will be protected. Patients, local businesses, and those expected to deliver health care are extremely concerned. Many Americans believe that so far this has been nothing short of an absolute nightmare. Madam Secretary, we're looking to you for honest and specific answers, as we know you will. Our families and small businesses deserve to know. I now recognize Ranking Member Levin for his opening statement.
At this point, we're going to recognize Health Subcommittee
Right.
Ranking Member McDermott
Thank you,
to
Chairman.
deliver his opening statement.
Thank you, Mr. Chairman. Welcome, Madam Secretary. I've enjoyed working with you during the President's first term, and I'm very pleased that you decided to stay. Others have left, and I'm sure that there are things that might be attractive in leaving, but your willingness to stay and serve the people should be recognized, because this is a very daunting task that you face. Implementing the Affordable Care Act on top of managing Medicare and Medicaid will not be easy. Enrolling millions of people by the end of the year is a Herculean task, which is why the leadership and continuity you provide is so critical. Your experience both as an insurance commissioner and a governor, you know what it's like on the other end, so it's going to be very important to have you at the top talking about what happens. The President's budget really is an effort, in my view, to reinvigorate a search for common ground and the common good. Unlike our colleagues on the other side, the President has been clear about his willingness to tackle the tough issues. Unfortunately, it doesn't mean much when the House Republican leadership refuses to engage in meaningful conversation about shared sacrifice or deficit reduction. You just heard that we're 3 years into this. Well, what they did for the last 3 years was they would not negotiate, and in fact, Republicans have been unrelenting in their zeal to get rid of the ACA, even though it's the first serious and successful attempt ever in this country to curb health care costs. It's projected to reduce the deficit, even with its benefits, by more than $1 trillion over the next 2 decades. Despite 33 House votes for repeal, the Supreme Court ruling, and the presidential election results, their efforts to destroy the law continue. We know they won't get rid of it, and they know they won't get rid of it. John Boehner even said the other day that it's the law of the land. And they also know that there's more than one way to skin a cat. Republicans know that the best way to secure a government that won't tax or regulate them is to create a government that can't do anything. Starve the programs, and the people won't fight for them. Cripple the government, and no one will understand what they need. The sequester cut 8% of the program management budget for CMS, a direct hit to ACA's implementation efforts. It was obvious they did it. Their budget raises costs for current senior citizens by repealing Medicare improvements and ends Medicare as we know it for people nearing eligibility by turning it into a voucher program. Ironically, the CBO says the Republican Medicare voucher proposals would lead to higher national health care spending. We've dealt with access with the ACA. We now have to deal with costs. That's what is the implementation that we're going to be into presently. Their policy is not a clever one. It doesn't lead to better care. It isn't either ethically or fiscally responsible. In contrast, our Medicare reforms in the ACA were based on reality, not red hair. Through our efforts, Medicare's per-person growth rates are historically low and projected to remain so for the foreseeable future. Solvency was significantly extended, new payment and delivery system reforms, which will create a program that favors value over volume and helps drive the right cost, the right care to the right patient at the right time. It hasn't been easy, but that's why I'm glad you're still here. No one is better suited to the job. You understand the importance and the complication of state partnerships, and you're asking for what you need. $1.5 billion to get uninsured Americans health care, to establish sustainable spending and tackle the #1 cause of personal bankruptcy. That's a bargain at $1.5 billion. HHS staff are to be commended, especially those at CMS, because they've worked tirelessly to improve changes that overhaul nearly every Medicare payment system. They're creating a whole new infrastructure on the promises of ACA, and they've done it on a shoestring. We know you don't have the resources you need, and the job has been made infinitely harder by false and misleading attacks by opponents. Now, enough is enough. It's time for my Republican colleagues to work with us and the administration to ensure effective implementation of what the American people have demanded, a simpler, more fair health care system that's established by the Affordable Care Act. They had 4 years of advertising against it, and they reelected the president overwhelmingly because he put it in place. I hope today's conversation is a productive start toward that eventuality, and look forward to hear the discussion.
Thank you. Welcome to the Ways and Means Committee, and we have your written testimony. You are now recognized for 5 minutes.
Well, thank you, Chairman Kemp and Ranking Member Levin, subcommittee chairs, and thank you, Ways and Means Committee, for the opportunity to discuss the President's 2014 budget for the Department of Health and Human Services. I think this budget directly supports the overall goals of the President by strengthening our economy and promoting middle-class job growth. It ensures that the American people will continue to benefit from the Affordable Care Act. And it provides much-needed support for mental health services and takes steps to address the tragedy of gun violence. We are proposing to strengthen education for our children during their critical early years to ensure they can succeed in a 21st century economy. The budget secures America's place as the world leader in health innovation so that it remains a magnet for jobs of the future, and helps to reduce the deficit in a balanced, sustainable way. I look forward, Mr. Chairman, to answering your questions about the budget, but first I want to just share a few of the highlights. The Affordable Care Act is already benefiting millions of Americans, and our budget makes sure that we will continue to implement the law. By supporting the creation of new health insurance marketplaces, the budget will ensure that starting next January, Americans in every state will be able to get quality health insurance that fits their budget. Our budget also addresses another issue that's been on all of our minds recently: mental health services and the ongoing epidemic of gun violence. Now, we know that a vast majority of Americans who struggle with mental illness are not violent, but recent tragedies have reminded us all of the staggering toll that untreated mental illness can take on our society. And that's why we're proposing a major new investment to help ensure that students and young adults get the treatment they need, including training 5,000 additional mental health professionals to join our behavioral health workforce. Our budget also supports the President's call to provide every child in America with access to high-quality early learning services. It proposes additional investments in new early Head Start child care partnerships, and it provides additional support to raise the quality of child care programs and promote evidence-based home visiting for new parents. Together, these investments will create long-lasting positive outcomes for families and provide huge return on investment. As we prepare the next generation of Americans to succeed in the 21st century economy, our budget also makes sure that America remains a world leader in health innovation. The significant new investments this budget contains for NIH reflect our commitment to furthering the biomedical research that will help create good new jobs and advance the cause of cures and medical science. The new investments in health IT will allow us to continue to support the development and use of compatible electronic health record systems that have huge potential for improving care coordination and public health. Even as our budget invests for the future, it also helps to reduce the long-term deficit by making sure that programs like Medicare are put on stable fiscal trajectory. Medicare spending for beneficiary grew at an historically low rate of 0.4% in 2012, 0.4% in 2012, thanks in part to the successful implementation of the Affordable Care Act's $800 billion in saving provisions that strengthen the Medicare program. The President's 2014 budget achieves even more savings. For example, the budget allows low-income Medicare beneficiaries to get their prescription drugs at the lower Medicaid rates, resulting in savings of more than $120 billion over the next 10 years without sacrificing their drug benefits. In total, the budget would build on the Affordable Care Act's cost containment measures, generating an additional $371 billion in Medicare savings over the next decade, reducing the deficit and putting Medicare on sounder financial footing. Our budget also reflects our commitment to aggressively reducing waste and fraud in all our programs. We're proposing an increase in mandatory funding for our healthcare fraud and abuse control program, an initiative that last year alone saved taxpayers nearly $8 for every dollar that was spent. And we're investing in additional efforts to reduce improper Medicare, Medicaid, and CHIP payments, and to strengthen our Office of Inspector General. What all of this adds up to is a budget that will equip HHS to support the administration's North Star of a thriving middle class. It will promote job growth and keep our economy strong in the years to come, while also helping to bring down the long-term deficit. And I know many of you have questions, and I'm happy to take those now. Thank you, Mr. Chairman.
Well, thank you very much, Madam Secretary. Mr. Marchand is recognized for 5 minutes.
Thank you, Mr. Chairman. Welcome, Madam Secretary. I'm concerned about the impact that the President's health care law will have on the small businesses in my district. HHS recently announced the delay of the choice option for small businesses in the 33 federal exchanges. The Small Business Majority, a group that has been a witness before this committee, called your decision a major letdown for small business owners and their employers. Operational challenges have been cited as the reason for delaying the choice option. Can you please detail exactly what these operational challenges were and the specific problem that ultimately led you to delay the program?
Yes, Congressman, I'd be glad to answer that. The SHOP exchange will be up and running in every state in the country in 2014. The SHOP is a small business market exchange. In it, small business owners who now pay about 20% more than their large competitors for insurance will finally have competitive choices, transparency, and an ability to leverage the kind of buying power that the large competitors have. The SHOP exchange, as written, had 2 components. One was a choice for business owners, and that will be up and running. And the second was an opportunity to offer those business owners then to give their employees a variety of choices of plans. A lot of feedback from both insurance companies and from some business groups indicated that that would be a very hard second tier to get set up year one. So what we have determined to do is in at least the federal exchange, and the state-based exchanges can have the full program up and running because they're just doing one state. In the federal exchange, every small business owner will have a choice of plans, will have competition, and will be automatically in a larger pool with rates that the Congressional Budget Office has estimated will be significantly lower than what they are able to pay right now. What will happen year 2, Congressman, is those employers then, if they choose, can give employees the wide choice of plans with an aggregated premium. That's the only portion that's being delayed.
But what specifically led to the decision to delay that program?
It really was feedback mostly from insurance companies and others that operationally to try and get the aggregated premiums, all the choice plans available up and running year 1 was probably going to lead to some major glitches, and we really took that advice seriously. So all business owners will have an opportunity to have competition and a choice of plans in the small market. And then again, in year 2, offer from then on the opportunity for their employees to choose among a variety of plans.
Due to the delay, do you believe that some small businesses may choose to completely drop their health coverage for employees and opt to pay the fine instead of provide coverage?
I do not, sir, because what we know is that the employer will have a choice. The employer will have a competitive market for the first time ever. That will be up and running in every state in the country. What the law then says is that the employer, if he or she chooses, could offer employees a choice of every plan in the market. That's the phase that will not be in place, at least in the federal market, until year 2. So employer choice will still be there. The smallest employers will qualify for an up to 50% tax break to offer their employees coverage through the shop. They will have negotiated rates, they will have transparency, and they will have competition and be part of a larger pool that right now they don't have.
Do you anticipate making the same decision to delay the implementation of the exchanges and the entire Affordable Health Care Act?
No, sir. We will be up and running in every state in the country, October 1st for open enrollment and January 1st, 2014 for the plans to begin.
Has a follow-up question. Has HHS made any preparation for how to meet the added cost of providing care for the potential 10 or 12 million people that might gain permanent residence status under any kind of an immigration bill?
Sir, we don't do anything about what the Congress may or may not do in the future. No, sir.
So there's been no preparation made whatsoever for that large group of people?
We are working with the law as it is right now, and believe me, have our hands full to try and make sure that the law of the land is carried out.
All right, thank you. Time's expired. Mr. Thompson's recognized.
Thank you, Mr. Chairman. Madam Secretary, thank you very much for being here. I want to second my colleague, Mr. McDermott's comments on how pleased we are that you're where you are and that you're staying. It's been a pleasure to work with you through the rollout of this measure, and you and your team has been fantastic. And it's going to require that you continue that as we do as you do the rest of the implementation. It's disheartening to me that so many people are working so hard to discredit the Affordable Care Act rather than to make sure that it works and that our constituents and the American people have access to quality, affordable health care. And that's when that's another reason why your work is so important, to make sure that we get over what I'm sure will be a bump in the road when we look back on this. Thank you also for your provisions regarding mental health. As someone who's been working on gun violence issues during this Congress, the mental health issue is clearly an important one. And I'm glad that you brought it up, because it's not enough just to say mental health is the problem and use that as the beard to ignore the bigger inclusive problem. Not only is it part of the issue, but it's part of the issue that we have to deal with, and funding for that is certainly part of it. On a specific issue in the health care reform measure, and you mentioned it in your opening statement, and that's the audits to deal with the fraud and the abuse, the RACs, I believe they're called, where you're working with the hospitals to figure this out. Can you talk a little bit about that, or maybe better to I'll leave it up to you. You can either talk about it now or get back to me on it. But I know that I'm hearing from a lot of hospitals, especially the small ones, where they're having some trouble going through all of the procedures associated with the RACs. I recognize that we're saving Medicare money doing it, and I recognize that we have to do it. I'd just like to know how it's being done, and specifically the provisions on the education and training portion.
Well, Congressman, I think there are two facets of the fraud initiative. One is improper payments, and as you know, many improper payments are not fraud. They are mistakes, and they are clerical errors, and they are miscoding, misbilling. So we are ramping up fairly dramatically the technical assistance support effort to work in advance with providers to try and make sure that at the outset the bills are submitted correctly, that we pay the proper amounts correctly, that we don't spend a lot of time going back and not only dinging hospitals or providers, but have to try and recollect that money. The effort that I was commenting on that's really saving about 8 cents on the dollar, $8 on the dollar, is the new effort that the President has directed both the Attorney General and I to partner in, and has resulted in an amazing collaboration with U.S. attorneys on the ground, with state attorneys general, with the so-called HEAT task force, including our Office of Inspector General and members of the Justice Department, and really ramping up the prosecution of individuals who are bent on stealing healthcare dollars from consumers. So we have had an unprecedented number of not only takedown operations, sting operations, but returns to the federal Treasury in both Medicare trust fund payments and Medicaid payments to the states that are really resulting in making sure that people understand that this is a bad way to steal money from the government. It's a bad way to steal medical services. So we are hoping that the mandatory requests for new resources would be granted. It's one of the single best investments with an 8-to-1 return, and we have now 3 years of a very impressive track record to share, but we would really like to ramp those efforts up.
Thank you. And then can you get back to me
Sure.
on the education and training piece of the
I'd be
RCA
glad to.
portion? Okay. Thank you very much. I yield back, Mr.
Thank you. Ms. Black is recognized.
Thank you, Mr. Chairman. And Madam Secretary, I want to go to the issue of the Navigator program. You recently released the preliminary rules for the Navigator program that's enacted in the healthcare law. And the rule that was released last week reported that you expect to pay these navigators up to $48 an hour. While HHS has not released the estimates on the total number of workers that would be hired in this program, it has been reported that California is requesting 21,000 of these navigators, and would cost taxpayers about $1.5 billion in California alone. Have any other states released estimates on how many workers that they need to support the Navigator program in their state?
Well, Congresswoman, there are two issues. The funding proposal that was released by our department is aimed at the states where we, the HHS, will be operating a federal marketplace. That is not California, which is going to have a state-based market, and California Resources will pay for the California Navigator program. This is really an effort to make sure that the 41 million eligible uninsured Americans, some of whom have never had health coverage before, are aware of the law, aware of how to sign up for the law, and have some assistance and help along the way to understand the benefits and make some good choices for themselves and their families. We do not have a salary scale set in the funding proposal. We're trying to make some estimates of a range of scale that was recommended to us by community groups on the ground and others, but that is not an hourly rate that's set in the funding proposal.
So you don't have an hourly rate at this point in time?
We do not.
This $48 that was reported is inaccurate?
We tried to estimate an amount based on what we found community workers and community groups charging on the ground, but we will be looking at competitive funding proposals, and the payment to these navigators has nowhere nearly been established.
So let me make sure I hear what you're saying. So in those states that have chosen to do their own exchanges, they will be paying for their own navigators.
That's
but for
correct.
those that you go in, that you're going to run as a federal program, you're going to pay for the navigators in those states. Is that correct?
Yes, ma'am. We have
So
now.
if a state has chosen to do it, they're not going to get the assistance. They're not going to get grants. They're not going to get any money to help them with their navigators.
They have.
But those that run by the federal government will be paid.
The states that have chosen to run their state-based exchanges have planning dollars available to them and operational dollars for year one until they are able to be fully up and running, where the fees for the insurance companies operating in their exchanges will take over the operational costs. So they have planning dollars available within the Affordable Care Act. This grant announcement is for the states that have, that we will be operating a federal marketplace.
Okay, so it's a very complex application. From what I understand, it's about 15 pages long, run by 3 different agencies. Is there a way to take some of the complexity out of the application?
We're talking about the Navigator application?
Oh, no, the application for someone to apply for for the program itself, to get into the exchanges.
To get health insurance.
That's right.
First of all, we are working hard to, I think, make the application as user-friendly as possible. And just to give a little perspective, because I've seen some reports about how daunting this will be, we looked around the country, and the average health insurance application, if you would go get a paper file from California or Nevada or Georgia, is in the 20-page range. A life insurance application is about 23 pages long right now in the market. We're trying to actually make this a much more user-friendly proposal. What we know is that this will depend on how complicated the family situation is. If someone is single and looking for insurance and has a relatively simple tax situation, we think it could take 15 minutes online to go ahead and apply. If it's a complicated family situation with more information needed, it could take longer and require more information. There's a tension, Congresswoman, between making sure we verify correctly the income levels and what is actually eligible, what the person is eligible for.
And I'm going to reclaim my time because I see my red light. Madam Secretary, what I would like to also know, that I'm not going to have time to ask, but if you could send it to my office in writing, I want to know what the qualifications, educational qualifications will be for these navigators. I also want to know what, why the brokers that are already educated in insurance are not going to be eligible to be a navigator. So if you could just respond back to my office for that, I appreciate it.
Happy to.
Thank you, Mr. Chairman.
Thank you. Mr. Blumenauer is recognized for 5
Thank you,
minutes.
Mr. Chairman. Thank you, Madam Secretary. Welcome to Congress. Sometimes it must seem a little surreal for you because you hear tales of woe and doom and gloom and all the problems of the healthcare system, all of which were very much in evidence for 10 years before we passed the Affordable Care Act. And you have made clear in your many presentations about the changes that are already underway. The reforms are making a difference. Costs are going down. It's not easy, and it's been made harder because this Congress chose, instead of working with you to accelerate reform, chose to tilt at windmills, attempting to repeal it, and cutting away at the resources you need to do a difficult job well. I find no small amount of irony that a Congress that could not summon the courage to close military bases instituted an independent commission to help them. Now there are howls of outrage that there may be an independent commission if Congress doesn't do its job dealing with health care reform costs in the future. But I have 2 questions that I would offer up for you. One deals with the notion of where we are in terms of actual health care savings. It's been documented by independent sources that health care reform will produce approximately $1 trillion worth of net budget savings over the next 20 years. There's work underway, and I, again, deeply appreciate the flexibility and partnership of the department working with my state in Oregon, accelerating those reforms, and if successful, and it's tough, but it looks like there's an opportunity, it would produce savings if they were taken on a national level that would achieve over $1 trillion in 10 years. And my first question would be that you might comment on some of the reform opportunities that you see in Oregon and elsewhere. My second question, and I don't think there will be time to get into it in the 5 minutes I have, and I would welcome a written response, deals with some of the areas that don't have to be partisan, that we could move on quickly to accelerate reforms. I've suggested to my colleagues on the Health Subcommittee that we could take, for example, a piece of legislation I'm honored to co-sponsor with my friend Mr. Gerlach that would have a secure ID for Medicare recipients that might cut down on fraud and mistakes. I have bipartisan legislation that deals with end-of-life care. 90% of the American public actually support having some assistance helping them navigate those difficult challenges. We have bipartisan legislation that, with Dr. Rowe, with Mr. Hanna, Dr. McDermott, that would give what 90% of the people want. It's supported by the Hospital Association, insurance companies, Ellen Goodman's Conversation Project that will be coming to Washington, D.C. next year. I would like to know in writing if we can work with you and your department to try and make some progress helping Americans be able to deal with the challenges they face at end of life and making sure they know their choices and that whatever those choices are, they'll be respected. I'd appreciate that in writing, but maybe you could talk about health care reform in the remaining time.
Well, thank you, Congressman. I think that while there is a lot of attention and focus on what's happening in the insurance market, which will affect, I would say, a relatively limited number of Americans, what is going on in the delivery system that the authors of the Affordable Care Act and those who supported the Affordable Care Act wrote into the bill is, to me, the most exciting and has the biggest potential for long-term gain. And it really deals with delivery system reforms that affect everyone, whether or not they have coverage now, whether or not they'll be in the new market, whether or not they will have new choices for insurance. Oregon is one of the country's leaders, no question about it, but we're also seeing a number of other states. We're working closely with Arkansas, with Massachusetts, with others who are really trying to do a couple of fairly straightforward things. Better patient care, better protocol when a patient hits the healthcare system, better public health, so looking at prevention programs that actually lower costs, and care improvements that improve the deficit and lower costs. And what we're seeing is some pretty dramatic improvements already. And there is real hope that those kinds of system changes could produce not only long-term financial benefits, but long-term health benefits. America still spends almost twice as much as any developed country in the world on health care per capita, almost twice as much. We have more people uninsured than any developed country in the world without health benefits.
All right.
And we live sicker and die younger than most of our competitors. So that's not a great formula for a global competition.
Okay, thank you. Time has expired. Mr. Young is recognized for 5 minutes.
Madam Secretary, thanks so much for being here today, and thank you for your service. Today you've assured this committee that the exchanges will be up and running pursuant to the Affordable Care Act on time and functional October 1st of this year. Encouraging to hear because it is in fact the law. I do know there's a lot of anxieties. I visit with my constituents and other stakeholders about this matter. There's also some anxiety with the release of this budget, certainly anxiety that I harbor about the costs of these exchanges and said implementation. The President's budget has HHS spending $1.5 billion on exchange grants in 2013. That's an increase of over $300 million compared to last year's estimates for fiscal year 2013 spending, despite the fact that most states have chosen not to create their own exchanges. The budget also anticipates an additional $2.1 billion in spending on exchange grants in fiscal year 2014. Now, through the original law, Congress appropriated $1 billion for implementation, but you, Madam Secretary, were also given unlimited authority to fund state exchange grants through 2015. Now, press reports say there's about $235 million left in the law's original implementation fund. Can you confirm that number or tell us how much the department has spent on the exchanges so far, and from what other funding sources these expenses are being funded?
Well, sir, I think that if I heard correctly, there were a lot of numbers in your question. You've conveyed a fairly accurate picture. When this bill was passed in 2010, the Congressional Budget Office estimate was a $10 billion administrative cost to full implementation of the law. And you are correct, in the law itself, there was $1 billion appropriated, a tenth of what the nonpartisan CBO recommended be the cost. I think we have done an extraordinary job, frankly, here in 2013, allocating and using judiciously the $1 billion that we had. We do have about $230 million of those dollars left. We will use those and some additional resources in 2013, and we have asked for additionally $1.5 billion in 2014, and that's really to get the IT hub, the call center, the IT up and running, and have...
I'm aware of the significant logistical and information technology challenges of this. Some would say that the design of the project may have been too ambitious, but nonetheless, certainly sensitive to that and all the good people who are working on such implementation.
Well, and I think the good news is we're well under what the budget estimates were.
But $1 billion was originally, that was authorized in the original law. That's what Congress provided. That's what it was said was required by this body when it passed the Affordable Care Act. But we have a doubling of the projection for setting up the exchanges by Congress, and this is with less than half, I want to emphasize, with less than half the states participating. And so I guess, you know, I have a concern that if more states did participate, that would cause the cost to explode even further. Is that your estimation?
No, sir. And in fact, I think that characterization is a little bit misleading. We have right now 31 states and the District of Columbia running all or part of the up-and-coming marketplaces. So the 2/3 of the state are actually engaged. Some of them are not running the entire program. They're running the plan management part or consumer outreach or both, or they're running the entire thing. In the remaining states, we will be setting up the entire exchange as a start, but we are actually in conversations with lots of states who said we would really, once it gets up and running, we see ourselves taking it over.
Thank you. Finally, if you don't receive the additional funding requested, is this going to preclude the ability to launch the exchanges on time? And if not, what is your contingency plans? Presumably there is one.
Well, we are confident that we will launch the exchanges. We will be open for open enrollment October 1st. The hub is basically built and paid for, and we'll be using the remaining resources that we have. We are using every opportunity we have to look at my transfer authority within HHS and the dollars that we have. But you're absolutely right. We have a law that is the law of the land. The Supreme Court has confirmed its constitutionality. There are millions of Americans looking forward to the benefits, and we have requested additional resources to make sure that we can fully reach out to folks who need it.
I yield back.
All right, time has expired. Mr. Kynes recognized for 5 minutes.
Thank you, Mr. Chairman. And Madam Secretary, thank you so much. And we do appreciate your service. And I think outside of the President and perhaps Speaker Boehner, you've had the toughest job in Washington the last 4 years. And it may get a little bit tougher when we go into some crucial phases of implementing the Affordable Care Act. But just today, I think it's a little bit refreshing that we have some colleagues on the other side that are concerned about HHS moving too slowly in the implementation of the Affordable Care Act. And I share Mr. Marchand's concern about the delay in the SHOP Act, in particular, the impact on small business owner and the small group market. But listen, I want to ask you a question in regards to the sustainability and the cost containment that we're already starting to see with these reforms being implemented. Because I think it's a great story that really hasn't
been told. And the law is starting to slow down the growth of health care costs. For instance, the U.S. healthcare spending grew at 3.9% the last 3 years. This is the lowest growth rate in over 50 years. Medicare per beneficiary spending rose by, just as you pointed out in your testimony, 0.4% in 2012. Medicaid per beneficiary spending actually dropped by 1.9% in 2012. And one of the great untold stories that just happened a little over a month ago is CBO's recalculation in the 10-year cost figures on both Medicare and Medicaid. And CBO determined that both Medicare and Medicaid will now spend $700 billion less over this next 10-year period than previously estimated. Medicare will save $382 billion reduction in spending, roughly 3.5%. Medicaid, $239 billion reduction. And the question will be whether this is sustainable, but there are also more instances of cost containment and cost recapture that you and your department have already gone after. Nearly $15 billion in fraudulent Medicare payments are being recaptured now because of the beefed up authority and enforcement we give you under the Affordable Care Act. Hospital readmissions are down 75,000, and hospital-based infection rate is the fourth largest hospital expense, so we're starting to move the dial in that area. The law has already led to nearly $2.1 billion in savings for American consumers through the medical loss ratio being overcharged, and those rebates are going out right now. The health care law also provides $250 million in health insurance rate review grants to states. They're using that as oversight and review of premium increases, which is having a real impact. And the growth of private plan premiums has also slowed. Again, it hasn't been a story told that much. Annual premiums for employer-sponsored family health coverage is down by 4% in 2012. It's the lowest rate except for one of the last 13 years. And so this is a real progress when it comes to cost containment, especially in these budget deliberations where healthcare spending is the largest and fastest growing area of spending we have in the federal budget. And we're seeing some real progress right now. But we also have 250 new affordable care organizations with a new model of delivery system and then payment reform, so it's quality, not quantity-based payments anymore. And I also find it striking that the President's budget before us today actually finds more savings in Medicare over the next 10 years than the Republican budget does. And that's because we understand that it's important we move forward on reform. We don't have the luxury of waiting 10 years before we start reforming the entire healthcare system. We have to be doing that now, and it has to be a comprehensive, holistic approach. But this is a tremendous success, at least initially in the first 3 years of the passage of the Affordable Care Act. And I'm wondering, in your opinion, with CBO's recalculation of cost reductions, is this sustainable with structural reforms that are happening, or is it a remnant of the Great Recession that we're coming out of? What are you seeing, and what's your opinion?
Well, I think that you've enumerated what is a snapshot of what's going on. In spite of some reports to the contrary, there is a very, very positive story to tell on cost reductions, on cost improvement, on care improvement, and that is with additional benefits for Medicare beneficiaries, with additional people insured, with additional coverage in the marketplace. So that is not sacrificing the beneficiaries to get those cost savings, as some would do in plans, but it is really enhancing the benefits that people are receiving. I think we have a great opportunity with the kind of delivery system reforms, again, that you, Mr. Kind, and colleagues made sure were part of the Affordable Care Act from the outset, driving toward a value-based payment system, looking at strategies to make sure that medical protocol was appropriate and paying for that, reducing the kinds of costs that come with avoidable hospital readmissions that are built into the system, and frankly, having insurance coverage under a vast majority of uninsured Americans will be another huge step forward, getting to care treatments at a much less expensive point in time, making sure that people don't continue to access emergency room care at a more expensive, least effective point in time, and really working on prevention efforts around obesity and smoking, which are beginning to show, again, positive signs. This has enormous opportunity and I think enormous potential to make sure these cost containment strategies continue into the future, and that health improves for Americans at the same time.
All right, thank you. Mr. Kelly's recognized.
Thank you, Mr. Chairman, and thank you, Madam
morning.
Secretary, for being here. It's good to see you. One of the questions I have back home, there's a company called Health South that does inpatient care. Now, when it comes to market basket cuts for inpatient the rehabilitation facilities, now, is there any policy behind this? Is this just a cut? And is that the market basket? Is that something, a term that you're familiar with?
Yes.
Okay. Well, and I wasn't saying it to be funny. That wasn't a gotcha. There's just so much here that we assume everybody knows. But for people that build their economic model based on future payments or repayments, it makes it very difficult for people like Health South then to develop their any type of business performance. So what was the policy that drove that?
Congressman, I think there is an enormous amount of analysis of the health system that goes on with every market update and every market basket proposal. And it really looks at cost outliers. It looks at the way services are used, where we're seeing, I would say, aggressive upcoding in some instances to try and recover, where there are regions of the country that have tremendous differences without care variations. So I would say there's an ongoing, enormous analysis. John Blum, who is sitting behind me, is the deputy in charge of Medicare services. And as you know, with each market basket update, there is also a public display and a lot of feedback, because we're always trying to balance effective cost strategies with beneficiary needs.
And I think that's one of the things, I think at all of us, we look at the Patient Protection Affordable Care Act, the intentions were great. The reality of it is really staggering, and it's the uncertainty of it. It's the unknown part of it, because the budget keeps changing and the costs keep changing, and as wonderful as the product was supposed to be at the end, I mean, it's almost like if you don't know where you're going, any road will get you there. And so we really attack providers. Now, I'm back home, and I'm talking to people that have independent hospitals, like healthcare or Health South, what they're doing. When we continue to say, well, the problem is that the providers are making too much money, we're going to have to find a way to dial that back. They're making too much money. So I got to tell you, from being in the private sector my whole life, I've never been in a situation where you just don't know what it's going to cost you going into the future. And one of the things that the Patient Protection Affordable Care Act has done, I don't think this was intentional. It has driven a wedge between employers and the employees, between the owners of the business and their associates. It is forcing people who have had long-time relationships, have been to baptisms and bar mitzvahs and first communions and weddings and funerals, and it's portraying the owner of the business as someone who doesn't want to do something for his associates. And a lot of my friends, Bill Patterson back in Erie, for example, he's got a lot of employees. You know what he has to do now to meet this? He's got to make them part-time employees. Now, when I used to look at a work week, I thought 40 hours was a work week. No, it's 30 hours. And it may get down to 10 or 15, whatever we need to make the numbers work. This is what bothers me, and this is what really scares the living daylights out of small business people, because they don't know where they're going. And it's apparent to them that the government also doesn't know where they're going. And the costs keep escalating and escalating and escalating, other than Washington, D.C., where all you have to do is pick somebody up by the heels and shake the money out of their pockets. For people that actually have to go to work every day with a plan to be profitable, and cost as a huge factor in it, because it drives either the end price of the service or the product. Gosh, we've done these people a tremendous in-service. It's been a disservice all across the board. We are destroying the most important relationship that we have. It is a trust factor between those that own the businesses and run the businesses and those that work there. And when you destroy that, when you get into the really tough times, when you really get into the hard pulls and you have to rely on each other to get through it, you better believe that we're on the same side. And I got to tell you, I understand the budget. I'm looking at the budget, and all I know is, yeah, we need more money to do it. And yeah, we're going to take care of more people. The reality of it is, ma'am, how many pages of regulations do we have now?
I can't tell you.
My understanding is in excess of 14,000 pages. The bill was 2,700 pages, and it's still being written today. So if I were to ask Mr. Where do you think this ends? When does this merry-go-round stop? When do we finally know what the cost of this is going to be? Not all these wonderful things of what could happen into the future, but the reality of today. For people who have to make a payroll, for people who have to keep their associates intact. They've trained them, they've educated them, they've provided tools and stuff for them, and now we're forcing them to separate that relationship that they had and making them adversity. They're against each other. That's what I don't like about this. The idea, great, affordable, accessible care for everybody. The reality of it is, it's not affordable. It's never going to be affordable.
All right. Time's expired. Mr. Pasquale is recognized.
Madam Secretary, thank you for being here again today. Many times you've been here before. I had a question on the President's BRAIN initiative.
I'm sorry, I'm having...
I'm sorry.
Thank you.
I had a question on the President's BRAIN initiative.
Yes, sir.
One of the investments that I think is particularly worthwhile. As the co-chair of the Traumatic Brain Injury Task Force, I'm well aware of the advances we have made in research on the brain in recent years. Pretty fantastic. Some good came out of the two wars when we facilitated this effort, when we accelerated the effort and got the DOD to understand what their responsibilities were. It took us a long time doing it, but in a bipartisan way we accomplished that. Now, according to the Centers for Disease Control and Prevention, each year an estimated 1.7 million people sustain a traumatic brain injury in our country. Unfortunately, TBI is a contributing factor to a third of all injury-related deaths in the United States, 30.5% to be exact. Beyond these numbers, TBI has become the signature wound of both Iraq and Afghanistan. 20% of the soldiers deployed are estimated to have experienced some form of brain injury. So it is clear brain injuries can impact anyone at any time. It's really flowed over into the research and the development into sports in our own country, male, female, all kinds of sports. And we've seen in our lifetime, in the last 5 years, the NFL finally owned up, and they're doing a great job in trying to reverse what has become a horrific situation among their own players. This $100 million commitment is not just coming from your department, but can you speak to the goals of the BRAIN initiative for all of us?
Well, Congressman, I think it is one of the exciting next horizons. Dr. Francis Collins, who runs the National Institutes of Health, sees this as a project that has a lot of parallels to the genome mapping project. We need to map the brain, because whether it's looking at Alzheimer's disease or the kinds of brain injuries that you've identified that wounded warriors are suffering, or concussions that affect our kids, and we don't know enough about what is both happening to people and how to deal with it, how to prevent, slow down, rehabilitate some of these injuries and traumas. So there is a public-private partnership initiative announced, which will include private foundations that are already working in the brain space, the Department of Defense, who has a great deal of interest in this topic, as you correctly outlined, the National Institutes of Health, where a number of the institutes are already doing critical research but could accelerate that further, and really in a shared collaboration do the kind of multi-year brain mapping, accelerated cures strategy that has been successful in a number of other areas.
Well, I've seen the help now as compared to the help 5, 6 years ago with our service members. It was a catastrophe in the beginning. Soldiers are now being saved, which obviously was not happening 5, 6 years ago. And this is a tremendous effort with many departments that are involved. How do you think service members are going to be helped potentially?
Well, I think
in your
that
mind?
I've had the opportunity in the not-too-distant past to visit the amazing research facility at Walter Reed, which is looking at a lot of these cutting-edge strategies in terms of rehabilitating the wounded warriors. And I think the research going on there, again, trying to identify what exactly happens when an IED blows up and what post-traumatic stress syndrome actually is causing to happen in the brain and how that can be dealt with in the future. That has, clear impact on hundreds of thousands of soldiers who are returning and trying to resume a normal life. So the faster we can accelerate this, the more we know. I mean, we know how to treat their limb injuries. We know what happens if they have to be stitched up. We don't know nearly enough about what has happened to their brain and nerve system, and I think the faster we can get to this research, the more help we can give.
Thank you. Thank you, Madam Secretary. Thank you, Mr. Chairman.
Thank you. Mr. Griffin's recognized.
Thank you, Mr. Chairman. Thank you, Madam Secretary, for being here. I appreciate your service. Appreciate you answering our questions today. I believe in health care reform, and I believe we need health care reform. And what I am particularly concerned about is reform of Medicare that my mother relies on, and Medicaid, which is not in this committee's jurisdiction. But I'm concerned about long-term permanent reforms, not tweaking at the edges. I believe that we need to strengthen these reforms so they'll be there for my generation. I know they'll be there for my mother, but I'm worried about my generation and the next generation. And I am particularly concerned about what we call in Washington mandatory spending, squeezing out a lot of the investments that we need to be making in breast cancer research and NIH research, Alzheimer, MS. A lot of people may not realize that a lot of that's from the discretionary side, and the longer we leave the mandatory side without reform, the more pressure it puts on those critical investments. And so that brings me to, you mentioned Arkansas, and I know there's a big debate going on with Arkansas, and you've been working with Governor Beebe down there on Medicaid expansion or some alternative to that. My view is we ought to have permanent, lasting reforms all over the country. I like what was approved for Rhode Island in early of '09. But I want to ask a few questions specifically about what's going on in Arkansas. Did you, and I have some of the correspondence with Governor Beebe, have you met with, I know you met with Governor Beebe, have you met with any of the legislators in House or Senate from Arkansas?
I have not, sir.
Okay. Would you like to meet with any of them? Would you be willing to meet with any of them?
Sir, we really, the way the Medicaid program runs, we negotiate with the state.
Okay. Have you seen the bill that is?
No, sir.
That is floating around? Okay. So if this bill, and the vote's coming up soon, I think it passed the Senate, it's going to come up in the House soon, at least the appropriations for it. The bill itself, I think, passed yesterday. If this passes, have you decided whether to approve it, or are you waiting?
No, sir.
Okay, so it's not approved.
Well, again, I'm a former legislator, former governor. As you well know, anticipating what any legislative body may do before they do it is probably not a very beneficial expenditure of time.
I'm familiar with that. So your staff hasn't seen, I mean, the bill's been published.
I assume my staff is in close touch with the Arkansas staff, but again, we have not looked at when the bill passes, we'll be happy to take a look at it.
Gotcha. I am very concerned about how we pay for the estimated $630 billion that it will cost for Medicaid expansion. I believe we need to take care of our most vulnerable, but I'm afraid that we're setting up expectations and making promises that we're not going to be able to keep. And so I would just continue to advocate. I will continue to advocate for long-term, lasting, permanent reform of Medicaid. And I believe you would find a lot of people on this side of the aisle who are willing to work with you in fashioning reforms that will make our Medicaid program stronger. Same with Medicare. Extend the life of it and raise the quality of care for people. And I thank you for being here today.
Thank you very much. Mr. Davis is recognized.
Thank you very much, Mr. Chairman. Madam Secretary, let me thank you for appearing. But more than that, let me thank you and your staff for the way in which you have handled one of our most precious commodities, and that is health care for the people of these United States. I think that you have done and continue to do an outstanding job. I was pleased to note, as you explained, the options that exist for small businesses, something that people have been trying to deal with for many, many years without coming up with anything that was going to be beneficial or helpful. I was also pleased to note that the exchanges across the board seem to be on target. That is, they're moving right along, notwithstanding all of the criticism, all of the efforts that there have been to discredit that approach and to discredit them. Two questions that come to mind. I'm pleased to note that health education, health awareness, health promotion, the utilization of individuals to interact with the general public, providing them with information, early screening and detection. I think all of these things generate cost savings that are sometimes almost immeasurable. Let me just ask you, how has the prevention, early detection, screening, these aspects of the plan been working, and how are people making use of them?
Well, Congressman, one of the, I think, very important features in the Affordable Care Act is a direction to shift from acute care to preventive care, and that's contained in all aspects of the bill. So insurance policies in the private market now have reduced the financial barrier for people to access preventive care. No co-pays, no co-insurance for mammograms and colon cancer screenings and vaccinations for kids, things that we know will keep people healthy in the long term or identify a problem early enough that it can be life-saving. Medicare benefits now have more robust preventive care strategies, including a yearly wellness checkup and a plan to sit down with a healthcare provider and make a strategy for the future, something that we know is benefiting the 54 million seniors who participate in the Medicare program. But there are also now community strategies underway and efforts to really, through our community health centers, through community health workers, trying and prevent hospital admissions by delivering care strategies at an earlier point, getting school-based health clinics into underserved areas so that children and their families have access to care providers. So I think all those strategies are really aimed at reducing the health burden that people feel, and that's not just for those individuals. They are more productive workers if they can go to work every day. They are more productive parents if they don't suffer from an illness. They live longer lives. They are more productive in their community. So this has an economic benefit beyond just the individual family and the individual patient. It has an economic benefit for communities and for our country.
Let me ask you, how have young people, young adults, been making use of the provision that they could stay on their parents' insurance policies until 26?
Well, we have about, at last count, think there are about 7 million young adults who are now enrolled in their parents' plan, and over 3 million of those young adults had no insurance at all before this provision came about, so that young adults in America were the second largest category of uninsured Americans, and for a number of them, that may have been risky strategy, but it was okay. For others who were identified with a serious illness or in an accident or had a health situation, they're facing a lifetime of bankruptcy. They may bankrupt their families at the same time. So this provision that allowed across the country young Americans to enroll in their parents' plan has been enormously successful.
Thank you very much. I yield back.
Thank you very much. Mr. Renacci is recognized.
Thank you, Mr. Chairman, and thank you, Madam Secretary, for being here. Thank you for your service. One of my colleagues was talking about small business. Of course, I was a small business owner for almost 3 decades before coming here just 2 years ago. And I know that the biggest problem with jobs and job creators are certainty and predictability, and I know this healthcare rollout is causing a lot of uncertainty and unpredictability. But even in the business world, when you have that, sometimes you have to redirect, you have to change, you have to make certain decisions. I want to read to you an email that I received, and it's from a worker in my district. He writes that upon returning to work, he was told that his hours were going to be reduced from a full-time 40-plus hour a week to 30 or less, which for him would result in approximately 25% decrease in income. The employer mandate penalty raises significantly the cost of employing full-time workers, especially low-skill workers, because the penalty is a higher proportion of their compensation than for the higher-skilled worker. Would you at least acknowledge that the employer mandate will hurt low-income workers the most, and what is the administration's plan to address the law's disproportionate impact on that vulnerable group?
Well, I would say, Congressman, that first of all, what we know about the market that falls under the employer responsibility plan is about 94% of business owners who employ 50 full-time workers or more currently offer health insurance, 94%. If you get over 200 people, it's about 98% currently offer health insurance. What we also know is that they pay significantly more for that policy that they are offering their workers than their large competitors do, because they don't have any market leverage. They can't negotiate with a hospital, they can't negotiate with a drug company to say, we'll send you 1,000 workers and you discount our hospital beds. So what we're looking at is capturing markets that already exist, but actually giving for the first time people some choices that they don't have. They will have competitive plans, transparent plans. They'll know what's happening going in. Their workers will not be penalized for a pre-existing health condition, which is a huge issue for a small employer, and they will be able to move forward. The employer mandate only falls on employers who have 50 or more full-time workers, and as I say, right now, 94% of them are in the market, but they're in a market that isn't very cost-effective for them.
But you have heard that most companies are looking to keep their employment less than 50 employees.
Actually, I have not heard that. I've heard a variety of strategies and some speculation about what may or may not happen. What we know happened in the one state where this was fully implemented with an employer responsibility provision was Massachusetts. And in Massachusetts, while the predictions were that business owners would drop coverage, that people would get out of the market, just the opposite happened. In fact, they have more small business owners in the market today than they did when the law was first passed. They didn't cut hours, they didn't shift rates, they didn't drop employment. And what I also know, Congressman, from talking to business owners across the country, is they lose good employees every day to large competitors based on the benefits they can or cannot offer. That this is a huge challenge for small business owners because they can't provide the coverage. For the first time, we will have virtual pools larger than they have, negotiated powers, transparency, and we think those market strategies will be enormously beneficial.
I hope you're right. I mean,
Me
again,
too.
as a small business owner and somebody who still has a lot of small business friends, you touched on costs, and it's kind of interesting because when I talk to my small business owners back in my district, they're talking about premiums up 52%, premiums up 35%. There's a lot of studies out there. Oliver Wyman's study says that many under the age of 50 will see rates increase significantly. Aetna CEO has warned premiums would double in some marketplaces. You know, that goes on and on. The president's health care plan at one point in time was a promise of a $2,500 reduction in family premiums. Will that ever occur? Do you see the president's promise of a $2,500 premium reduction for all American families occur?
Well, again, I don't think that was the president's promise. It was what the Congressional Budget Office estimated, that people would see a cost decrease as we moved into a fully insured marketplace. And I think, Congressman, what we know is that the CBO, you know, is a nonpartisan objective body. They're looking at strategies in the market. What you are referring to in terms of current rate increases, first of all, is not impacted by the full implementation of the Affordable Care Act because it's not in place yet. And secondly, is really a situation where there are costs going up and down, but what we know is that they're rising at a much slower rate right now than they did 3 years ago before this law was passed. We have insurance departments, many for the first time, with aggressive rate review strategies in place where they are actually looking at the rates, they're rejecting double-digit increases, and we have the so-called 80-20 rule, which has never been in place before for insurance companies, where they actually have to spend 80 cents of every dollar on health benefits, not CEO salaries, not marketing plans, but health benefits. And the companies that didn't meet that threshold returned about $2 billion last year to customers. People all over this country got checks back from their insurance companies. So there are some market strategies in place that are cost effective.
I think I'm out of time.
Time is expired. Ms. Sanchez is recognized.
Thank you, Mr. Chairman, and Madam Secretary, thank you so much for taking the time to appear before the committee today to discuss the administration's fiscal year 2014 budget. Budgets, simply put, are just a reflection of our priorities, and our priorities should be very clear: protecting our seniors in their golden years, giving our children quality education so that they can achieve their dreams, and properly funding health care to keep our families in good health. And I was pleased to see that the President's budget does address many of those shared priorities. In particular, I was happy to see that the President's budget adds $1.5 billion in new funding to implement the federally facilitated and state partnership exchanges that will help provide health care insurance for over 25 million people, that the President's budget invests $1.4 billion in new early Head Start child care partnerships. That's an issue that's incredibly important for Southern California. That it increases funding for the Food and Drug Administration by $280 million to improve food and drug import safety, that it continues to invest in the National Institutes of Health, and that it increases funding for vital Title X family planning programs by $30 million over last year's request. All of those, I think, are important priorities that I think every American family can benefit from. And as a working mom, I have a particular soft spot in my heart that the President's budget would improve both the availability and the quality of child care. I hear far too often from parents that the lack of affordable and quality child care is a significant barrier for them to work. But what I want to really focus in on is something that's been touched on by my colleague Mr. Kind and others in passing, and that is the savings that the Affordable Care Act produces. Because something that I find somewhat paradoxical, if you will, is that the Republican budget that we saw included all of the ACA's Medicare savings and taxes in that budget. So on the one hand, I hear from my Republican colleagues, they claim that the ACA destroyed Medicare and levied a heavy tax burden across health care. But on the other hand, they passed a Republican budget that retained the ACA's savings. So, Madam Secretary, I'd be interested in hearing about some of the savings that the ACA has produced and your comments on the paradox that, on the one hand, folks seem intent on repealing ACA, but on the other hand, they want to retain the savings from ACA.
Well, I think the President believes very strongly, as we do in the Department of Health and Human Services, that keeping our commitment to the seniors of this country that was made in 1965, when my father officed in this building and sat on the Energy and Commerce Committee and helped to write the Medicare law and just turned 92, and he's pretty happy that he did.
I'm sure you are too.
I am, that we are very concerned that, on one hand, Medicare beneficiaries continue to receive that commitment and that promise, and that we find strategies that continue to look at deficit reduction and long-term growth in the plan. And I think that's what's captured in the President's budget. A ways it was part of the Affordable Care Act, $800 billion worth of savings, and we are very much on track to fully implement that with additional benefits. People said you can't do it, you know, it can't be done, you can't deliver good care and cut costs. Well, I think we are on our way, and we're in year 3 of doing exactly that. We see that same strategy into the future, where you can actually figure out care strategies that work to benefit a growing number of seniors. We have 11,000 people a day turning 65 in this country, each and every day. So we have the largest number of Medicare beneficiaries ever involved in the program, and yet we are on a historic low in spending, 0.4% in 2012. Never been seen before, and as Congressman Kine said, the CBO has reconfigured their projections into future years. So I think the President's budget captures the notion that there are very effective strategies that deliver appropriate care, make sure that we take seniors' needs into account. We continue to update quality programs, at the same time constrain the costs into the future.
All right, thank
you for
you.
your comments.
Mr. Ryan is recognized.
Thank you. I guess I should pick up where Mrs. Sanchez left off. Difference in our budget approach is where we make sure that all the Medicare money stays in Medicare. The chief actuary of CMS was here just a year ago saying you can't spend the same dollar twice. You can't, on the one hand, count savings from Medicare to pay for Obamacare and count it as savings to Medicare. He went so far as to put an appendix in the report to that effect. The other point is, in our budget, we put a reserve fund, which is a budgetary mechanism to address any inadequacies in the provider community that may arise if the case occurs where we feel like providers are restricting access to beneficiary because of these cuts. So that's just to answer the difference with the paradox, so-called. I got 3 questions, and you just released your budget this week, Madam. Good to see you, by the way, Madam Secretary. First, on the means testing for Part B and D, you have in your S9 tables, you have a $50 billion savings associated with that. Before, we've had mutually agreed on policies which got us $30 billion in savings. Where's the delta? Where do you make up the difference, the $20 billion?
The difference, Congressman Ryan, is that there is a new formula rather than having, I think, what were in the past 4 different categories. It's now 9. The lower limit
is the top still 80, or does it go up to? It goes up to 90.
The top is 96. 196.
No. The percentage that the beneficiary pays of the.
Yes, it's still 90%.
90%. Okay.
Yes.
Okay.
But there are more categories.
More categories. Is it still
floor,
kicking at
different
80,000 for an individual and 100?
I can
60
keep doing this. I mean, I'd love to get you that in writing, just so I make
yeah,
sure
I just really want to know. So
there are more categories, and there's a slightly different starting point and a different ending point.
Okay, different starting point on income, or different starting point on threshold, on percentage of the premiums that the person bears themselves.
The percentage of the premiums that the person bears themselves is the same.
That's what you. Okay.
Yes.
All right. So the $20 billion is a pretty big difference when you're looking at a $30 billion
And I'd be happy to get you all the details.
Okay, so your Medicare Advantage demonstration program, which I think scored at $8.5 billion, where you're offsetting 71% of the hit to the ACA in 2012, then it goes to 32 and 16, if I recall. I don't see that here in the budget. Did you not put that in your budget? That's a pretty substantial change in mandatory spending, especially for a demonstration program. Is that not in your budget?
It's in the baseline, Congressman. It is still going on, and I think the very good news is we are seeing beneficiaries choose higher quality programs, and we're still very much on track to actually pay Medicare Advantage plans at the same rate that fee-for-service plans will be paid on even a faster pace, including the quality demonstration plan. So
But
it's all working very well.
You're sticking with the formula of phasing it out in 2014?
Yes.
Okay.
Wanted to make
IPAB. I'm trying to watch time here. I'm not going to ask you to pour through your budget here, but in the past, you have not had attributed any savings to IPAB in your budget before because your threshold of growth rate, GDP plus 0.5, was above what you estimate cost growth to be. But now you have savings starting in 2021, 2022, 2023, so that IPAB is actually starting to score positive savings. How do I interpret that? Does that mean that you believe excess cost growth at the end of the budget window is starting to perforate the GDP 0.5? Or are there new proposals associated with IPAB that accrue those savings?
Congressman, there aren't new proposals that accrue those savings, except for the fact that this budget does capture what the President's belief is, which is different than the Affordable Care Act, which is that IPAB should kick in at GDP plus 0.5
Right.
rather than GDP plus 1.
But that was in your budget last year as well.
I understand. This is really based on just the actuary's estimate of what will happen in outlying years and when it, right now, as they look at the snapshot into the future. As you just heard, the CBO estimates have revised the long-term strategy. I think it can be revised again if we stay on a sustained cost reduction, but that's just a reflection of when they feel that the trigger point might meet with a point.
So that's that question. So the actuary is now saying the IPAB mandate, keep spending within GDP 0.5, which last year's budget didn't happen in the first 10 years because cost growth was below that. Medicare spending was below that. Now they're saying it's being triggered, so it's going to occur in 2021?
If you could just answer briefly.
Can I get back to you on that?
All right.
Yeah. No,
my understanding
it has
was
huge
that,
budget effects in the out years, so
Right.
I want to.
All right. Thank you.
I thought the old projection was actually in 19 that IPAB would trigger, and it's now been moved to 21. That's what I need to check.
Okay.
That
We'll
was
get back to you.
certainly my understanding.
Thank you. Ms. Schwartz is recognized.
Thank you, and I'm pleased to have you with us, and appreciate some of the good information that's been discussed this morning, particularly in relationship to the incredible progress that you've made in the last 3 years in implementing the Affordable Care Act and in containing the rate of growth and costs in both the private sector and in the public sector, and particularly in Medicare and Medicaid. So some really important work is going on in this country, and I think we've moved that dial forward, and you have, and the administration has, in really quite extraordinary ways. So it's bodes well for the future as we stay on this course. There are a lot of challenges as you face, and I know in states like mine where there are real issues where the federal government's going to have to step in. You're going to have to step in to assure that Pennsylvanians benefit from the increased opportunity to buy insurance, and I hope we continue to build on some of the really important work we're doing in some ways on healthcare delivery system reform. So I wanted to ask you specifically about an issue you know I've been pushing on pretty actively. I won't be surprised that I would raise this issue, but it's one that actually has some bipartisan support, as you know, which is the repeal of the sustainable growth rate, finally making a decision legislatively. I know you need us to do that, which is to recognize that we are not going to implement the sustainable growth rate. We should not. We're not going to cut physician reimbursement in this country by 10 or 20 or 30%, which is all a possibility. And the budget that the President has proposed actually says that we're going to repeal SGR and that we're going to replace it. And you added, which is very important to me, it's not just about saying this failed. I wasn't here when it happened, but it failed, and we're going to recognize that. But it really is about moving forward in a way that does sort of universalize the what you've been talking about some this morning, which is that we should be paying our healthcare providers differently, that would make sure that all providers in this under Medicare meet quality standards, that are accountable for that are transparent, that we help them do that. We're doing that, but that we improve the health status of our seniors in particular. I think this have a rollout for younger people as well, but that we actually pay them in a way that encourages that. Encourages them to coordinate care and to meet these quality standards and contain the rate of growth and costs. I've written legislation to do that. There's been a lot of interest on part of the Health Subcommittee here on Ways and Means to pass legislation that would give you the tools to do that, that would build on these models so they wouldn't be just interesting demonstration projects that are making a very big difference, or in states where they're really doing important work on this. We're doing that, but actually changing the way we reimburse physicians in this country. And I appreciate the language that you've put in. And what I would ask you to do is to speak to how you think we get there. And I know it requires us to take action. And I asked the chairman, and I know that Mr. Brady's been very helpful on this, but to really see if we can't get that done this year, rather than just yet again saying we're not going to implement the SGR, but we're going to keep that uncertainty for physicians and health providers in this country. And my concern, of course, is that if we do that, we hold them back from really embracing some of these new, different ways of delivering health care in a way they want to, hope to, and that actually meets the needs of our seniors in this country. You want to help us on that and help us figure out your leadership on this could be very important in moving us in this direction.
Well, Congresswoman, I know you've had a great deal of interest in this for a long time, and I appreciate your leadership in this area. I think the President shares the concerns that, first of all, the lingering uncertainty of the SGR cliff really is probably the single biggest issue threatening the care of our seniors. There's way too much time and energy that, frankly, doctors spend every year coming to Capitol Hill trying to get a fix that then takes them down the road for the next 10 or 11 months, and then they start all over again. So having a long-term strategy we are eager to work on. What we have proposed as part of this budget is, and our baseline assumes that the SGR is fixed.
Which is great.
But what we'd like to propose is a couple of years of sort of status quo, if you will, which has been done by Congress a year at a time, and then working carefully with this committee and others who have a great deal of interest in this, and certainly the provider community, on formulating a value-based payment system that would be our future look at how we pay Medicare providers, very much recognizing that payment should be tied to outcomes. It should be tied to care delivery. It should be tied to protocol. I think there are ways to do that. We're beginning to see accountable care organizations and medical home models and a variety of strategies. And the other thing that's going to be in place, which is a key part of this, is the broad implementation of electronic health records, which for the first time will actually capture and measure what is actually happening in the marketplace. So we would love to work with you on
I would encourage you to work. This is really very bipartisan. There's a chance for us to get this done, and I would hope we have.
It is,
very much.
And we have released a memorandum and outline in Phase 1 and Phase 2 with our friends on the Energy and Commerce Committee as well, and we're working in a bipartisan way as well as in both committees on this issue. Dr. Price is recognized.
Thank you, Mr. Chairman, and welcome, Madam Secretary.
Thank you.
We're talking about the budget here. Your comments in opening remarks talked about this budget strengthening the economy, providing middle-class job growth, and a, quote, thriving middle class, unquote. And I just thought I'd share with you a couple examples from the real world. Car dealer in my town, 168 employees, because of the ACA. Because of the ACA, 166 of those employees will be moved from full-time to part-time, 28 hours a week. A fellow visited my office this week here in Washington, has a number of Burger King outlets, over 900 employees, moving all but 5 of them to part-time because of the ACA. Madam Secretary, that's not going to lead to a thriving middle class. That's not going to lead to job creation. This bill is harmful to the economy, harmful to job creation. And as a physician, you and I have had conversations, I can tell you that I believe it is fundamentally harmful to the quality of care and access to care that's provided by the docs out there who are trying just as hard as they can to take care of their patients. To that point, this budget has $374 billion in new reductions in Medicare spending. $307 billion of that 374 out of the provider hide, out of the doctor payment. That's not a positive move. The guys and the gals my age out there practicing medicine are looking for the exit door. What's their strategy to be able to survive in spite of the law being put in place? The EHR is a classic example. You got rural docs, single practice physicians out there in rural communities, small communities, trying to care for their patients. And this imposition by the federal government makes it such that they're going to have to close their doors because they can't put in place the requirements for the EHR. There's a piece of legislation that Ms. Black has authored that would solve that. I would urge you to take a peek at that. I want to ask a couple very specific questions. The first is on the in-office ancillary exception and closing that in-office ancillary exception. As you know, oftentimes services provided in a physician's office are more efficient, more cost-effective, have higher quality of care than in any other setting, and yet this budget closes the in-office ancillary exception for things like radiation services and physical therapy and the like, something that MedPAC themselves said ought to be equalized in terms of payment so that you don't incentivize treatment at one venue or another over the objection of the patient or the physician. Is there any rationale to why the in-office ancillary exception is being closed? Maybe you can get back to me on that.
I just wanted to verify, Doctor, what I thought was the case. And what we're looking at is the utilization factor that often on the same day we're seeing an increased billing, but I would like to get back to you in writing with some of the rationale behind what you've just identified.
That'd be great. In same-day treatment, same-day utilization of services is oftentimes the most convenient for patients.
That's true.
May not be for government, but for patients.
We're not trying to diminish the number of in-day. We're trying to diminish the number of billings that occur when a patient is actually accessing a physician.
Heaven forbid that the patient should be cared for in the physician's office. I understand that. Let me move, please, to Medicare Part B drugs, cancer care. The quality of care for cancer patients in this country is being harmed because of a decrease in access to care, because of a decrease in payment for cancer drugs in the office setting. Your budget proposes a further cut in cancer drugs through Medicare Part B drug services. Is there any rationale for that?
Actually, I think, Congressman, what you're referring to is what happened with the sequester cuts.
The cuts in sequester were ASP plus 4.3%. The cuts in your budget are ASP plus 3%, a lower amount.
But actually, the cuts that are proposed in the budget that we have put forward would not interfere with the administrative service of the cancer drugs. Those are held harmless. We are taking an additional cut from actually the drugs themselves. What we learned during the drug shortage is that it is not the pricing of the Medicare drug that has impacted a drug shortage at all. What happened in the sequester with that blunt cut of 2% across the board is the entire cut actually came out of the physician side of that puzzle. And it did not affect the cost of the drug. It affected the administration of the drug, and that's why some of the cancer centers told us they were choosing not to admit Medicare patients any longer.
Correct, and that's increased in this budget, Mr. Chairman. Thank you.
Thank you. Mr. Reed, recognized.
Thank you, Mr. Chairman. Thank you, Madam Secretary, for being here today. Madam Secretary, I'd like to take some of my time to focus on a very important issue to me, and that's the solvency of Medicare itself, and in particular Part A the Part A trust fund. You are a public trustee, obviously, for Medicare, and the report in 2012 indicates that Part A will be bankrupt in 2024. Do you agree with that report and remain, is that still when the trust fund will go underwater?
Well, I think with this budget, we've added 4 or 5 years to the life of the trust fund. As you know, the ACA added 8 years to the life of the trust fund, so repealing the ACA would actually accelerate that timetable significantly.
So the best that you did with this budget, under your opinion, is that you moved it 5 years. So that essentially means everybody who is 4 years?
4 years, I'm sorry, yes.
4 years, okay. So that means everybody who is 51 years of age today and younger are being promised by the President's budget and your office that Medicare Part A will be bankrupt. Is that correct?
Well, sir, as you know, first of all, it isn't bankrupt. It is that it would bring in less than is anticipated going out, and I think we have 2 opportunities here.
No, I don't think that's...
It isn't entirely out of money.
I believe it's 25% short. They're going to be reimbursing
As I
the
say,
providers
it brings
for this.
in less than it would
So what
have.
term, just so we're using the same term, what term would you describe that as?
Well, bankrupt to me means it's out of money. I just
How
want
would
to
you-
make that
what-
clear, that there is money in the trust fund. But
What term would you describe that? Because I've had this issue with people on the other side of the aisle, and they say bankrupt is not the right term. How would you, as an official, represent that status? Insolvent? Underwater? Underfunded?
well, it's underfunded, I would say,
Okay.
based on current projections of what will happen with cost strategies. And I think we have great opportunities between now and then to change those projections dramatically.
Between now and then. But as
Yes.
of today, the best we can do is say to people
Well,
that are
as I
50
say,
years and younger,
the vote taken by the majority of this committee would move that insolvency date much closer to where we are right now. It would actually accelerate the date because 8 years of the trust fund were added with the passage of the Affordable Care Act. We would add another 4, and we would love to continue to work on strategies with this committee, keeping Medicare benefits in place and making sure that we can accommodate them into the future.
So then the plan I'm hearing from the administration is that we're going to take each year small steps to just push the number out 1 or 2 years and not fix the problem in perpetuity. See, I'm interested in fixing the problem in perpetuity. I want Medicare to be solvent. I don't want people that are 50. I don't want people who look at that 2024 date that was in your 2012 report and say, I'm 54, and all you're telling me is that it's going to be bankrupt. I'll use the term bankrupt, underfunded, the term you'll use. I think that's a problem. I think that's a real problem to send to American seniors and people that are getting to the point of retiring, and I want to find out what the plan is, and all I'm hearing is we're going to take it each year by year, and we'll move that number 1, 2, 3, 4 years.
Sir, I didn't...
What's the long-term plan you're advocating?
We would love to work with Congress on a long-term plan with the contingency that the long-term plan is not to destroy Medicare as we know it. And that is what has been put on the table, that in the future, seniors would not count on a guaranteed set of benefits. What they would have is a voucher. They would negotiate for their care in a system where everyone projects that Medicare would pay, beneficiaries would pay huge amounts.
And I'm familiar how you've categorized and classified the House Republican budget and the proposals on that. But the bottom line is that the system's going bankrupt. It's going to be underfunded. We need to solve it. And all I'm hearing from you today is the administration say, we can't change the program. Medicare as we know it cannot be changed.
Actually, sir, in the last 4 years...
Do you think, the question I have for you, Madam Secretary, and I don't mean to get into this give and take here. The question I have, do you think we can balance or make Medicare solvent in perpetuity by leaving the system in the exact same way that it is today?
I don't think the President or our administration supports leaving the system exactly as it is. And I would suggest in the last 4 years, sir, that with the legislation passed and with the budget that's before you, more significant changes are being put forward than have been put forward in decades. We would love to continue to work on how to preserve Medicare well into the future, keeping the promises that we made in 1965.
All right,
Time's
thank you.
expired. Thank you.
And now we'll go back to the beginning. I just want to note for the record that our budget does have a guaranteed benefit in it. Madam Secretary, last week, Wall Street Journal columnist Peggy Noonan dedicated her column to the wisdom of Lee Kuan Yew, who's the visionary leader who really created modern Singapore. And in describing his book on insights on China and the United States, in her words, Mr. Yu is bullish on America's immediate prospects, but concerned about the long-term future. And she noted that he's greatly concerned about our prevailing culture. And to quote him, a major problem is the day-to-day images of violence we expose people to through television. And Madam Secretary, I've worked on mental health issues, and I'm curious as to what your thoughts are on the linkage between violence in our culture on TV and the movies and video games, and mental health for kids and young adults, particularly troubled young adults. And are you concerned about the pervasive violence in our culture and entertainment industry?
Well, Mr. Chairman, I am concerned certainly about the pervasive culture of violence, both throughout media, in the entertainment industry, in movies, on TV, in video games, but also on our street corners. The number of children who live in extraordinary violence day in and day out, they don't have to turn on the TV, they have to walk outside. So I think we have a culture of violence in this country that is alarming. It clearly has different impact on different people, but there's no question that I think it does have at a minimum a desensitization for a lot of developing minds about what the impact of violence is, and certainly for someone who is disturbed may have even a more frightening impact.
Does it concern you then that the federal government provides subsidies to some of these industries, often through the tax code? And should the federal government be in the business of subsidizing something such as this that may contribute to the breakdown of mental health in this country, or contribute to this culture that people find outside, as you will, and the desensitization that occurs on the street as well as in the minds of those who are troubled?
Again, I think, Mr. Chairman, that's an appropriate conversation for those of you who are looking at the tax code to have. I do feel that there are lots of influences throughout our culture that impact folks, and what the appropriate balance is between industries that we want to encourage and censorship and what they do, I think is always open for debate. But I do share your concern that there is a pervasive culture of violence, both through the media and the entertainment industry, but also I think, America is a violent country, and that's acted out in neighborhoods and on street corners on a regular basis, and that has an impact on our health, on our mental health, on our communities, on our kids.
All right, thank you. Mr. Levin's recognized.
Well, Mr. Chairman, in a way, I'm glad you kind of shifted the discussion from Mr. Reed's approach to the issue of violence. Because I share your concern on that, and I'm hopeful that the Senate will act on gun violence in the next weeks and bring it up to the House. And we can look at the tax code, too. I'm sorry that Mr. Reed is still here, and I just want to say something, if I might, because I think we have a friendship. Look, the health care reform isn't going to be repealed. I think everybody should accept that as a given. And for those who wanted it repealed, I think the case has become more difficult because of the diminution in health care cost increases. They've been going down now for 3 years, Madam Secretary.
Yes, sir.
And there's some evidence that in part it's because of health care reform.
Will the gentleman yield?
Well, let me just finish. Okay. Also, there have been some clear benefits, and you mentioned, Madam Secretary, some of them, the millions of younger people now insured. As an example, the millions of seniors who now are paying less for prescription medicines. So I think with that situation, it's hard for those who opposed health care reform to be sure what to do. And I just urge that there be resistance to overstating, to doom and gloom, and I think often to kind of scaring people. That's why I think the Secretary resisted your characterization of Medicare going bankrupt. On this committee, we have faced underfunding of Medicare many, many times. You were in control for a number of years, and there wasn't this perpetual long-term resolution of the problem. But again, many times we've faced underfunding, and sometimes as a result we have reduced provider reimbursement. What healthcare reform really does in good measure is to begin the path of changing from fee-for-service to a very different reimbursement system. And while there's some agreement across party lines on this, in terms of scare tactics, sometimes they've described IPAD as a death panel, when it's really not that at all. So let me just quickly ask the Secretary, and then if there's time, I'd be glad to yield. I think another kind of doom and gloom approach of those who never wanted the health care reform, it's not going to be repealed, is to talk about premium increases. So just address quickly, if you would, your feeling about what's going on.
Well, Congressman, the insurance plans are in the process of beginning to submit preliminary estimates on rates in the new marketplaces. Those will be negotiated by either the state-based markets or the federal market, and by later this summer we will have a clear picture. Again, what we know from the Congressional Budget Office is that the estimate is that rates will be significantly more competitive than people find them right now. There will be an elimination of a lot of the overhead administrative costs. There will be competition as a market strategy, and I've seen this as an insurance commissioner, does work. That when plans have to compete side by side and it's very transparent, that in and of itself drives prices down. And so we are anticipating having people, if you compare policies to policies, what they have now and what they're going to have, a very beneficial set of rates and benefits that people will have an opportunity to choose from, some of them for the first time ever in their lives because they've been locked out or priced out of the market.
Appreciate that. All time has expired. I appreciate Mr. Reed's concern about the need to save Medicare. The clock is ticking. We need to act now, Republicans and Democrats. I don't see that as frightening. I see that as a genuine concern for a program that's in very severe financial straits. To try to bury our heads in the sand is really the wrong thing for our seniors. I think the only scare we heard was the witnesses claim that Republicans want to end Medicare as we know it. Didn't that win the national award for the political untruth of the year just 2 years ago? Maybe we'd be better off if we actually came to the table together, figure out how we're going to save Medicare rather than throwing out what everyone knows has been discredited. And to that point, I'd be cautious about claiming that the slower growth in health care costs come from Obamacare. Independent experts don't say that's the case. In fact, many of them believe that's because this is the worst economic recovery in 70 years. 20 million people can't find a full-time job. Millions more have just given up looking for work. It's Jimmy Carter days for them. And since the bottom of the recession, you're more likely to be forced to go to food stamps to feed your kids than actually find a new job. And so it's clear that if you can't find full-time work and you can't feed your kids, my guess is you're not going to the doctor. That's what's more likely slowed the growth in healthcare. So I'd be cautious at a time when the stimulus claims were exaggerated and the sequester claims were exaggerated. I think on healthcare, let's stick to the truth. On this point, and Mr. Chairman, I believe you were recognizing me. I apologize while you stepped away. Online, this is the marketplace timeline for the exchanges, and that's for the public as well as lawmakers to track how the exchanges are on track. But as I look at it, what I see is deadline after deadline missed. It's as if the agency is in disarray trying to meet the October 1st deadline. The final market rules regulation was missed. The payment notice rule was missed. The business rules for information technology, that's 2 months delayed. You recently announced a delay in the choice option for small businesses. You've also delayed the basic health care plan for year 5 of it. And so these delays are having real impact. Real people are concerned about these delays, and the failure by the agency to meet these deadlines raises real concern. So my question is, do you have a plan B? Do you have a contingency if the exchanges are not ready, up and running with a fully informed public by October 1st?
As I answered before, Congressman, we will be open for open enrollment October 1st of 2013, and we will be enrolling Americans across the country January 1st, 2014.
So at this point, you've had no discussions within the agency on contingency plans?
Well, we have lots of contingency plans
for not meeting the October 1st.
No, we are determined and
Right.
on track to meet the October 1st deadline.
So you can assure this committee there will be no further deadlines missed, no further delays in the implementation of the exchanges?
We are on track to meet the October 1st deadline.
The question, again, because I think we're all concerned, Republicans or Democrats, you can assure us there'll be no further
Congressman, I can only
delays.
tell you what I'm telling you. We are on track to meet October 1st. I can't tell you what exactly will happen at every step along the way, but I can tell you that is the determination. We are on track to meet it. We test it.
Well, you're not on
marking it.
track to meet it. That was the question.
Pardon?
You're not on track to meet it. You've missed
We
deadline
are
after
on track to
deadline.
meet the October 1st deadline. Yes, sir,
So there
we
will
are.
be no further, and again, I'm just trying to get to the bottom line. There will be no further deadlines missed, no further delays.
Again, I don't know quite what that means.
Well,
Will a rule and reg be a week later than it might say on the paper? It could. We will be open for business October 1st.
So, no delays, that's great news. No further deadlines missed, that's great news. We're still waiting as small businesses for information on the business information notices 2 months late. Is that being delayed again this week, next week? So are we seeing another ongoing delay there?
I think, sir, that is not ours. It's the Labor Department's notice, but my understanding is it's imminent. That is not an HHS rule that's coming out.
Okay. Thank you very much, Madam Secretary. Mr. Rangel's recognized.
Thank you. Thank you so much, and again, thank you for your service. I'm concerned about the American people that are now doubtful as to whether or not they would have health insurance, and also the fact that I don't know whether history will record such political opposition to any president with a national plan. All of my political life, I had hoped and dreamed that we would have universal coverage, and now we have it. And for some reason, it's become a political issue. 40 attempts or 39 attempts have been made by the Republican Party just to repeal it. Not to substitute it, not to improve it, but to repeal it. And of course, they substitute that with just confusion that it's not going to work, it's going to fail, as though there were only Democrats or potential Democrats that were going to be the beneficiary of the program. So we have to find some way to bring truth to the American people, no matter what their political persuasion is. And I hope that you can do this by telling me exactly how many Americans would be affected, since we're going to assume that the president has won, the Supreme Court has sustained this, and the first question is, Obamacare here to stay, politically speaking? Is there anything that you can think of besides withdrawing the president, having a recall with the president, or another case in the Supreme Court? Obamacare is here. So you would suggest that the best we can do, if we don't like it, to improve it, to deliver it, instead of just opposing your efforts. My question is, how many Americans are going to be affected anyway? Those that have insurance are not going to be impacted, right?
Well, I would say, sir, in terms of the new marketplace,
Yes.
a fairly small number of Americans will be impacted. About 41 million eligible folks who don't have insurance at all, and another 14 or 15 who are in the small market and individual market.
Do you know the political persuasion of these 40 or 41 million people that have no insurance at all?
Do I know the political persuasion?
I mean, are
No.
they Democratic people here that we want to hurt, or Republican people, or are they just
They're Americans.
Right. What could the Congress do to make certain that we provide, to help you to provide universal coverage at the least cost and the best quality? What would you expect this branch of government to do to help the executive branch to do this for all Americans?
Well, I certainly think a huge step forward was the passage of a comprehensive health reform bill, which has been proposed by Republican and Democratic presidents for over 70 years. So we finally have a framework to work on. You asked earlier, sir, though, how many people are impacted, and what I gave you is an answer for the marketplace, the new insurance piece. I think every American will be impacted and benefited by delivery system changes, better care, better population health, more effective ways to deliver care in the future, payment for value instead of volume, and making sure that we no longer continue to be the nation who spends the most with mediocre health results. And that's where we are right now. And we are on track to look at some care strategies, thanks to elements of the Affordable Care, thanks to the Innovation Center, thanks to what's going on, that could really change that profile and make us much more competitive in a global society.
Since you have been unable to tell us whether you can give assurances that these programs are going to be open on time, is it safe to say that your assurances to say that we are on track would be dependent upon some cooperation from the Congress? Or is it possible that we could legislate something to actually avoid you following the guidelines that you have been planning?
Well, again, sir, I don't know how much more specific I can be, but I think we are definitely on track to implement the law as it is anticipated and have open enrollment start in every state in the country on October 1st.
And there's an assumption
involved.
that you're going to have a positive support from the United States Congress to do this.
Well, it would be helpful.
All right. Thank you. Mr. T-Berry for the final question of the morning.
Madam Secretary, welcome. It's great to have a Buckeye here with two Michiganders as the chairman and the ranking member, kind of even it out a little bit. I'd like to send you an article from the Columbus Dispatch, a paper that you're familiar with, from either last week or the week before to Mr. Renace's point of a small business owner who has less than 50 employees that was planning to grow his business beyond 50 employees and publicly said in the article that he's not doing that because of the Affordable Care Act. It is a problem that I've heard about from a lot of small employers within Central Ohio, but this one happened to be willing to say it to a reporter and explained why. I think it would just be helpful for you to have that. I'm not trying to be political about this. But Mr. Rangel, Mr. Chairman, just asked about the political persuasion of people without insurance today. I was on this committee when we passed this bill, Mr. Chairman, and I like you a lot, but there's a lot of concern from everyday people out in my district, at least, regarding the implementation of this bill. And the President over and over said, if you like what you have, you can keep it. Let me tell you, Madam Secretary, a story from my district, from a company that I met with a couple weeks ago, self-insured employer. And the executive team, including the HR person, have been looking at this and trying to implement this law with their employees. They provide health insurance to their full-time employees. They have a great plan. Their employees love their plan. Their employees think they're going to be able to keep their plan. Through their ability to look at this implementation, they have found out that their plan, with no added benefits, will increase by 10% at least. The $63 fee that they're going to be paying alone will cost over $1 million with absolutely no change in their policy because they already participate in what's called the, just so I'm clear on this, the plan that covers people with pre-existing conditions, and they already take care of their employees through the early retiree subsidy program. They don't get a penny from that. So they are trying to, Mr. Chairman, figure out what to do next. What's clear is they're going to have to increase cost if they keep what they have to those employees. Those employees don't know that yet. And I'm not trying to be difficult here. I'm just trying to explain the concern that members on our side of the aisle. I'm not going to defend the old system, but they're super concerned about the new system because what may happen, Madam Secretary, and again, I'm not trying to be difficult, is that they may choose to put all their employees into the exchange. So their employees may not be able to keep what they like, which was a promise of this committee when the majority was in the minority's hands. And their employees don't even know that yet. In the satisfaction surveys that they have received from their employees, from the plan they have, are overwhelmingly good. And this is a company that has prided itself on health care coverage, dealing with obesity, dealing with cancer, dealing with pre-existing conditions. And the choices, in all honesty, from non-political HR people there, I could see it in their eyes how troubled they were with where they were going to have to go, and asked me, is there any sort of opportunity to change this for folks like us? And I said, I don't think so. You might want to contact Sherrod Brown. He might have some better luck doing it. In all honesty, and again, not trying to be political, because I think ultimately, Madam Secretary, and I don't revel in this because these are my constituents, and they're Democrats and Republicans and independents and non-political. Their health care is going to change according to their experts for the worse. So I just like to think that maybe that you, and because I know your history and I know you care about this, that maybe you and your team can be more engaged with some of these employers who are very, very nervous about the future of a benefit that they've provided, and they're not the ones that we were trying to get at in terms of access to health care, if that makes any sense.
It does, and trust me, we are trying to be very engaged. I meet with employers in various parts of the country on a very regular basis as I travel around, and I think that as we move into full implementation, I'm hopeful that some of the projected fears will be relaxed a bit, and that people will have, it's very difficult until, the case you're talking about, Congressman, is a self-insured plan. So they are looking at some certainty in terms of what fees there may be in the market versus the penalty that they would pay if their employees then are tax eligible and they can do some calculations. I'm hoping in the long run that employers who have been in this market voluntarily because they find that a benefit to their employees will indeed move forward with that benefit. That's what we continue to hear from folks. And that for people who were locked out of the market because they did not have any affordable options, they didn't have any market leverage, they didn't have an ability to provide those benefits, will finally have some choices based on private plans in their state who have to compete for the first time with a new set of rules. But I will continue to do the outreach, and we would love to, you know, have a chance to talk to some of these folks about what exactly they're looking at.
All right. Thank you very much. That concludes today's hearing. I want to thank you, Secretary Sebelius, for your time this morning and for your testimony. And with that, this hearing is adjourned.
Thank you, Mr.